please.
Thank you very much, for this invitation, and also to Trevor for inviting me to this session. I was remarking to a colleague this morning that this is probably the first time I've ever spoken on global child health issues in a critical care congress, and I hope this is a real welcome beginning. I have some credentials to be here because for almost 20 years I headed a large group looking after neonatal intensive care in my own university till I saw the light and moved on to public health. So what I want to do this morning is to share with you a little bit about the context and the numbers around child survival, newborn survival, talk a little bit about causes of child deaths, and deliberately today, because I want to take on from where Giorgio left in terms of talking about solutions, what can be done within health systems. And there isn't time to talk about everything, so I'll focus on newborn mortality and intervention that we've recently begun, and also talk about a recent large-scale effectiveness evaluation of improved diarrhea management in rural Pakistan. We'll talk a little bit about the context of all of these in relation to global child survival and implications for policy. So to move on, you've seen this slide perhaps shown by Trevor earlier on in this Congress. This is a map drawn up by the Bellagio Group a few years ago, which is a spatial distribution of where 10.6 million child deaths occur annually worldwide. And as you will see, a large proportion of these deaths occur in sub-Saharan Africa, but also in South Asia. If you look at where these deaths occur, actually 10 countries of the world between them have about 2/3 of the total global burden of child deaths. And interestingly, in the context of newborn deaths, it's the same 10 countries that have almost 61% of the total global burden of maternal mortality. So one of the first points I would like to drive home is that while this map may look like a map of child mortality, it's also a map of maternal morbidity and mortality globally. If you look at time trends, over the last 20 years or so, there has been significant improvement in child survival globally. But a large chunk of that has related to post-neonatal child survival. And that is easy to understand because some of the interventions that lead to improved child outcomes are relatively easy to deliver through vertical programs for example, diarrheal disease management, pneumonia management, EPI. And the hard core of newborn mortality, which hasn't changed, both early and late, requires that these interventions be contextually different, that they also relate to maternal health, to reproductive health, to some of the social determinants that Dr. Tambolini was talking about this morning. So, ladies and gentlemen, as we speak, this is an issue of global concern, because if you look at what are our Millennium Development Goals for child survival and where we need to be by, let's say, 2015, if you look at where we are now, we are far behind as a globe in terms of the MDG4 target. If the MDG4 target is 32 as a global average, about 28 of that is currently neonatal mortality. So the point to drive home here is that without addressing newborn mortality, we can just as well forget about reaching the Millennium Development Goal for child survival, because this is the 800-pound gorilla in the room that you need to tackle if you are going to bring child mortality rates down. And as was indicated also in the earlier presentation, many countries of the world, notably in the very high burden regions, are seriously off in terms of targets for Millennium Development Goal 4. And in the context of South Asia, my own region, despite the fact that we have much better socioeconomic conditions, growth rates than sub-Saharan Africa, a large proportion of the population, particularly the rural poor and the urban slum dwellers, have mortality rates which are comparable to what you see in sub-Saharan Africa. Let's turn for a moment to the global pie chart for the causes of child deaths. This was drawn up very laboriously by some of us as part of the Global Burden of Death Study and also the Child Health Epidemiology Reference Group. And if you look at the global causes of death, 3 disorders, newborn, problems, diarrheal diseases, and pneumonia, between them account for about 75% of all child deaths. And while this pie chart may look discrete, the other important thing to note is that it really isn't discrete, and there is an overlap in these categories. To give you an example, if you take pneumonia as a disorder, a significant proportion of newborn infections also fall under the umbrella of pneumonia. So pneumonia, child overall, in association with neonatal pneumonia, are responsible for about 29% of all child deaths. I'm not going to talk about pneumonia today, but I will say a few words about diarrhea. Now, we thought we had licked this beast. Childhood diarrhea deaths globally have come down from the approximate 4.5 million deaths way back in the late 70s to around 1.6 million deaths currently. That's a substantial improvement through better improved recognition, management, oral rehydration. However, the burden or the incidence of diarrhea hasn't gone down. And if you look at the averages in terms of number of episodes of diarrhea per child per year, you'll find that over time, and in this particular slide, we have summarized 4-point estimates done in the early 80s, early 90s, late 90s by my group, and the mid-2000s. You'll find that there has been very little change, both in young infants and in children under 5, in the number of episodes of diarrhea per child per year, suggesting that we have perhaps not done enough in terms of preventive strategies. And also that in terms of how diarrhea impacts undernutrition and long-term outcomes like stunting, that we have a long way to go. Let's turn towards newborns, and just a few points to drive home about newborn care. First is the timing of newborn deaths. If you take what we know from DHS data in some of these high-burden countries, about half of all newborn deaths occur in the first 24 hours. By the end of the first week, 3/4 of all newborn deaths have already taken place. So you can imagine where health systems are poor in terms of access to the immediate neonatal period, where data reporting systems aren't quite geared to birth registration if births take place at home, that it is not a surprise that many people have missed the entire issue of newborn survival in the context of child survival. It is also important to note this because if you want to intervene and you do so in the late neonatal period, you've missed the boat because 75% of all deaths that are occurring, and some of them are potentially preventable, do so in the first week of life, in the first few days. In the context of the health systems, it's also important to recognize where these deaths are taking place. Now, I've told you the macro picture in terms of which countries of the world the clustering of deaths takes place. But if you look at within countries, even those with well-developed health systems, such as South Asia, where you have village-level health units, basic health units, feeding rural health centers, sub-district entities, and then referral hospitals, the problem is that quality of care in the context of maternal and newborn care is so poor at the lower end of the health system that when families are confronted with the choice of addressing maternal and critical illness in the newborn period, they vote with their feet. And how do they vote? They either try and access care in the upper end of the health system, which means that from a rural village, you will try and go to the district headquarter hospital. And because that is difficult and at times just not feasible at all, the other thing that they do is stay where they are. So remarkably, if you look at the statistics in terms of what we know from several surveys and also in-depth surveillance studies as to where these deaths are taking place, about 50 to 60% of all neonatal deaths, at least in South Asia, occur at home, in village settings, sometimes seen, frequently unseen. About a third find their way up the health system. So they do make their way to some facility of sorts, underscoring the importance of making that link with the facility. And about 5 to 10% die en route. And this has been, at least in our experience in Pakistan, remarkably consistent in several district surveys which have evaluated the pattern and distribution of newborn deaths. Let me turn towards causes of newborn deaths, and you can imagine with most of these being clustered earlier on, a large proportion of these deaths relate to the major categories shown here, such as asphyxia, sepsis, and perhaps prematurity, with a spattering of congenital malformations. And these patterns are not constant, and I'll just say a few words about two of these entities. Let's look at asphyxia as a cause of newborn deaths. And asphyxia can clearly cause encephalopathy, which is recognizable to most practitioners. It can cause death as a consequence of encephalopathy or as a consequence of the acute event. And it can also clearly lead to some degree of disability, both in the medium, short, and perhaps long term. And our information in terms of the contribution of asphyxia to the global burden of the problem is at this point in time extremely poor. If you look at how the global burden of disease, for example, ascribes disability weighting to asphyxia, I mean, that disability weighting is minuscule. It's virtually non-existent. And that's one of the reasons why you do not see asphyxia accounting for any substantial number of DALYs beyond the deaths. Let me give you some figures on this. Here are data from rural Sindh, from our own studies, looking at causes of newborn mortality. And let's say asphyxia accounts for about a quarter of all newborn deaths. If you then look at what proportion of these deaths may be left with some degree of handicap, we have a problem because there have been no prospective studies. But we did a cross-sectional survey of 3 districts where we wanted to look at the contribution of asphyxia to morbidity and handicap in the population that was still alive. So in the district that I'm going to share some data with you from, when we evaluated this, 18% of all living under 5 children had a history suggestive of perinatal asphyxia. Not vague history, but clear history of failure to breathe at birth and seizures within the first 3 days of life. So if you just do an association with those kind of numbers, the contribution of handicap to the burden of morbidity following asphyxia is not minuscule. So if I were to draw from these numbers some extrapolations in the context of the globe, if we have about 0.9 million deaths due to asphyxia annually, we estimate that potentially, in terms of handicap until 5 years of age, they may not survive beyond 5, but they contribute to the burden of the problem in the health system. You're looking at about 1 to 1.5 million newborns left with some degree of handicap. This is a conservative estimate. And to this, you add another number which is uncounted in the context of newborn deaths. And those are babies born dead. So if you look at the contribution of intrapartum stillbirths, which by definition is a preventable entity, an extension of birth asphyxia, the total number added to the global burden of the problem annually is about 2.5 million or more. Beyond asphyxia, the next big entity is neonatal infections. And these have myriad presentations. They can range from just superficial infections to severe fulminant infection, which is frequently misdiagnosed. And despite institution of treatment, case fatality rates, even in good centers, can sometimes reach 40%, dealing with different multi-resistant and problematic organisms. Now, in the context of how infections relate to neonatal deaths, there is a transition. If you go to high mortality regions where neonatal mortality rates are greater than 45 per 1,000 live births, we believe that neonatal infections are a disproportionately large chunk and that they account for about 50% or more of all neonatal deaths. And this is borne out from several studies done in South Asia which have looked at this in community settings. As neonatal mortality rates go down, the contribution of infections, serious infections, to neonatal death does go down, but stays around about 25 to 30%. So infections are the next big chunk. So if you take infections, asphyxia, and add to it a spattering of prematurity, you've got about 80% of the total burden of neonatal problems that we need to tackle. So what can be done? is there evidence that there are interventions that can make a difference? A few years ago, as part of the Child Survival series, we did an extensive exercise of looking at the evidence base for child mortality as to what interventions could make a difference. And what we found at that time was that we already knew sufficiently about many interventions to confidently say that if they were implemented at scale, we could save about 55% of all child deaths. And these interventions, ladies and gentlemen, were not rocket science. If you look at some of them, they are simple things, and I will deliberately point out the interventions that relate to diarrhea or oral rehydration, zinc, breastfeeding, water sanitation and hygiene. You take these together, and these should potentially save about 40-45% of all child deaths. So the question really is, if this was as simple as this, why isn't this happening? So let me show you the reason why this isn't happening, and let's just look at diarrhea interventions and their global coverage for a moment. These are data from our forthcoming Lancet series on nutrition to look at current coverage rates of various interventions that could impact on diarrhea. So if you take safe drinking water, complementary feeding, you're looking at a huge range with many parts of the world only being able to provide these to about a third of their population. But it's been 10 years since the evidence base on the importance of zinc in the treatment of diarrhea has been out. And at least 4 years since the WHO UNICEF recommendation for improved diarrhea management with zinc and low osmolality ORS. And on this slide, you see the global coverage of that intervention in 2007. Not a single country of the world has been able to implement this evidence-based, recommended, simple, inexpensive intervention at scale. So it's not therefore a big surprise that we find that at this point in time we are still struggling with child survival in the very countries that have the high burden because we've not been able to scale up interventions. Newborn care is a more difficult area. And here, in order to understand what interventions worked, we took a very extensive exercise. This was an exercise that Gary Darmstadt and I did a few years ago with support from WHO and Saving Newborn Lives to look at the total global evidence base on community-based interventions that could improve perinatal and newborn outcomes in developing countries. We identified a list of 43 interventions that were selected for in-depth analysis, where we thought that there was good evidence that they may work. Now, 43 is a big number. In order to take that forward, we pared that down to a smaller set of 16 interventions that we then evaluated in depth, and this was published in the Lancet Newborn series as highly effective, cost-effective interventions that could be packaged together. And as I've said before, for child survival interventions, many of these interventions were, again, not expensive, not difficult, and not things that you would need to go and do a randomized controlled trial to see their effectiveness. And they ranged from better antenatal care to thermoregulation to breastfeeding to appropriate resuscitation at birth with a skilled attendance. In order to then see how we could deliver them in a health system where, as I've already indicated, the bulk of these deaths are taking place at home and health systems are weak, we attempted to package these interventions into family and community packages, outreach programs that could go through health workers from outposts, and clinical and facility-based care packages. We've recently published an improved version of this in Health Policy and Planning. But to cut a long story short, these interventions could be layered across a continuum of care from maternal to infant to young child as both community, outreach, and as I mentioned, clinical and facility-based programs. This is probably too small for you to see, but the information is available on these 16 interventions. And most of these interventions work optimally, not in isolation, but if they are linked together. So the maximum impact of an outreach program is only if you have a community program in place. And that a community program that promotes care seeking and improved behavior can only optimally function if you have a place to go to seek care. So the links, the vertical integration of this whole system is clearly important. We estimated how much difference would this make. So antenatal interventions implemented at scale could save about 15% of newborns, intrapartum a bit more, and postnatal interventions save up to about a quarter of all newborns. Taken all together, we could save, with this knowledge, at least 2/3 of all newborns at various tiers of the health system. And countries have the choice to make a phased implementation of these interventions to get maximum gains. But as I've said before, the challenge is that these interventions, like the diarrhea interventions I mentioned, are not available. And some of these, in terms of their coverage, are very poor. I just want to point out two, which is exclusive breastfeeding, something which is inexpensive, culturally relevant in many countries. If you look at the coverage rates of exclusive breastfeeding in the first 6 months, we are struggling still with figures close to around 30% as a global average. If you take something which has been out for almost 30 years, and is actually the logo on the Cochrane collaboration, the use of antenatal steroids for premature labor, the global coverage at best, as we speak, in the very health systems that we are dealing with, is no more than around 13%. So herein, ladies and gentlemen, lie the challenge of how do we take the knowledge and the words, the rhetoric that we have, to scale and implement this in health systems. So what needs to be done is targeting, packaging these for community implementation, linking this, as Dr. Tambolini said, to social development and community strategies that address them, tie these in within health systems, and monitor, especially the equity aspects of these intervention strategies. Because if you don't have a focus on the very poor, on those at maximum need, then you will see an increasing equity gap as you layer interventions in within health systems. So the question that we now turn to is, can this be done? It's one thing for me to stand up here and say, this is the theory, but can you do this in practice? And are there effectiveness measures, evaluations in health systems globally where people have demonstrated that this can make a difference? And I'll give you two examples from my own group's work in Pakistan, unabashedly, as a learning experience where we've also learned how outreach programs work. So these are studies done in an area called Hala, which is about 3 hours away from Karachi. It's a rural population. It's a district with a population of about 1 million, typical of any rural populations in the world, very poor people, and general indicators which are consonant with what you see in South Asian rural populations. We worked with the government program of community health workers called the Lady Health Workers Program. These are young girls, generally of grade 8 education, who are specifically hired by the government at pay scales which are around $50 a month with their traveling incentives. And their general charge is to provide MCH services, maternal and child health services. This is a program initiated in 1994, and generally it is in the form of a basic 6 months course of training with monthly refreshers. They also collect vital information, and their numbers now in Pakistan are up to 100,000. So it's a real innovation in terms of service delivery, an offshoot of the Barefoot Doctors program that you saw in China after the Cultural Revolution. Our first project was in 24 clusters in Hala, and I'm sharing with you data from the pilot phase. As a pilot, this was in 8 clusters, not small, 300 villages, 280,000 population. And the intervention that we evaluated here was a mix of two things. One, the creation and support of community support groups, community volunteers from those villages, who were largely charged with being gatekeepers and providing their own internal mechanism without any internal assistance of creating transport systems and supporting the permeation of key messages for maternal and newborn care in these villages. So that's creation of community volunteer committees. The lady health workers were charged with an improvement in their existing program of newborn care. So they generally work in two setups. They work either through door-to-door visits in their target areas for those in need, such as, for example, pregnant women, or they provide interventions through group sessions. The interventions that the lady health workers were charged to deliver are listed on this slide. Please note that they do not include antibiotics, any other commodities, nor, at least in this trial, active resuscitation. Most of the sessions conducted by these lady health workers were within the community confines with available resources. So as you see here, this group session is in a courtyard in somebody's house in the village. So they use available resources. And as I've indicated before, no monetary incentive is provided for this. This is generally part of their care. So this, in essence, is an effectiveness evaluation through an existing health system intervention. This was the situation when we started. As you can see, in both areas, control and intervention clusters, the perinatal mortality rates are extremely high, about 100, with early neonatal mortality rates of around 45. 2 years on, you can see a fairly visible difference between the two groups. And in quantitative terms, what you see is a substantial reduction in stillbirths and a significant reduction in neonatal mortality. When I first got these data from our group, I actually threw them out because I couldn't believe them. And I still have difficulty in terms of understanding as to how, without an actual obstetric intervention, we did not put a single new obstetrician in place. We did not increase the capacity for operative delivery within the same communities. How can stillbirths go down? And the penny dropped that this whole intervention had led to a significant behavior change in the target villages, as exemplified by these two slides. Look at the patterns of care seeking for skilled attendants went up from a baseline figure of about 19% to 34%. And a lot of this in the public sector. So if you look at where these deliveries are taking place, most of these deliveries are taking place in the government health facility of the target district. So this proves the point in a way that if you create the linkages and behavior change communication strategies, empower communities, and have the necessary referral system available to the public sector, people will go. So this whole notion of providing community care as a standalone, localized entity within the community with no link to the health system is probably a misplaced notion, that you can create those linkages and they can make a difference at scale. Other things happened as well, so I wouldn't oversimplify what we experienced in the pilot. And this is just one slide which I want to show you in terms of breastfeeding patterns. At the time when we started exclusive early within the first hour, breastfeeding rates in the community were around about 50%. And today we have almost universal initiation of breastfeeding within the first hour after birth. So those things can also take place at scale within the health system. And these data have now been verified in our scale-up phase also. Our second intervention in the same area, but in different clusters, dealt with diarrhea that I mentioned earlier on. And our hypothesis was management of diarrhea now have zinc in the management of diarrhea for 10 to 14 days, low osmolality ORS, and the use of antibiotics only if indicated, for example, for bacterial diarrhea. The situation in Pakistan for diarrhea management is probably no better than many other developing countries. That despite all the effort and availability, ORT use at best is around 50%. And at this point in time, zinc use is negligible. As this was also an effectiveness trial, this was done in the same district, 16 clusters, 770 villages, and around 47,000 children who were kept under surveillance over this time period. And of these children, every fifth child had an in-depth period of follow-up for 10 to 14 days after they went. So I'm summarizing a very long trial which has spanned 4 years into just 2 or 3 slides. So you'll see that there was a formative phase, a pilot phase, and then an implementation phase. The trial involved health system intervention, including the private sector. So all public sector staff were, through the government apparatus, provided a refresher training course in improved management of diarrhea in the intervention clusters. There was, in addition, a social marketing scheme, and deliberately the social marketing of Zinc and improved diarrhea management was done at a scale and a level which is commensurate with what the industry does. So for this entire district, there were only 2 people placed for the social marketing component. The government staff were provided Zinc through the government system free of cost, but all the pharmacies and the private sector people had to buy Zinc at the cost that we believed could be affordable when this was implemented at scale. So here is a summary of what was provided and what was dispensed. And the point to take home is that the lady health workers were able to recognize disorders and dispense almost 5,000 out of 8,000 doses provided to them. It's a pretty high rate of dispensation. And when I say doses, it's not a single dose, it's a whole 14-day course. The same with private sector pharmacies. A fairly substantial, surprising number of uptake in terms of a new entity for the management of diarrhea. But more importantly, what difference did it make to outcomes? Here are the control clusters. And as you will see from what I've described before, this is really quite suboptimal and a cause of great concern for something like diarrhea, where evidence base for interventions has been around for a while. Look at the use of antidiarrheals. 50–60% of all cases received antidiarrheals in control clusters. If you look at ORT use, you're looking at an ORT use which is actually less than the national average, about 20 to 30%. And the use of antibiotics is around 1/3 of all episodes. When you look at what happened in the intervention clusters, you see an entirely different situation after 1 year of the intervention. You see both ORT and Zinc use rates at around 60%, but importantly, you see a significant reduction in the prescribing patterns for antibiotics for diarrhea in the same clusters. Very similar to what has been shown from small-scale efficacy studies of how Zinc used for diarrhea replaces antibiotics when given to healthcare providers. So this is one of the first effectiveness evaluations of how an intervention like this can be done within a health system at scale and can potentially make a difference. The question that arises is, did it make a difference to outcomes? And the answer is yes. If you look at hospitalization rates for diarrhea between the intervention and control clusters, it's a substantial difference between the 2 groups. So much so that when the government staff saw these data, it will now be very difficult for us to do our planned large-scale pilot. Our plan was to do this in 1 district and then go on to 10 districts. And now it's ethically very difficult not to introduce this at scale in all districts of Pakistan. So, ladies and gentlemen, I believe we have sufficient information about what we need to do to reduce newborn deaths and certainly child deaths in the context of major killers. We cannot get where we want by business as usual. We would need to scale up pretty rapidly by working with governments and communities what needs to be done for child survival. We have the interventions. We do not have a good handle on how we implement them at scale. And the way to do that, I believe, as I've underscored, is that we need to find innovative methods of implementing these at scale. And using community health workers and community strategies is now, in my opinion, not really an innovation, but a necessity in developing country health systems. Thank you for your attention.